It's a pleasure and an honor for me to present Dr. Patrick Vinay. So Dr. Vinay holds a bachelor's and an MD from the Université de Montréal. He also holds a certificate in nephrology and a PhD in biochemistry. After 2 years of postdoctoral training at Oxford University under Professor Hans Krebs, winner of the Nobel Prize in Medicine, he began a career in research at l'Hôtel Dieu de Montréal. He then joined the Department of Physiology's Membrane Research Group and became a full professor in the Department of Medicine while still continuing basic and clinical research within the nephrology service at Notre Dame Hospital. He has been focusing his academic and clinical activities on palliative care since 2004. Throughout the course of his 40-year career, Dr. Vinay has published more than 200 articles and scientific papers, the majority of which deal with subjects relating to nephrology and kidney metabolism. A talented administrator, he was president of the Fonds de la Recherche en Santé du Québec and chief of the Department of Medicine at Notre Dame Hospital, and dean of the Faculty of Medicine at l'Université de Montréal for 2 terms. He is active also in francophone circles through the Conseil scientifique de l'Agence universitaire de la francophonie, and was also the president of the International Conference of Francophone Faculties of Medicine. He is a member of the Royal Society of Canada and a knight of l'Ordre des Palmes Académiques de France. He is president of the board of directors of Living with Dignity. So Dr. Vinay is going to talk today on the advanced pain management. And so Dr. Vinay.
End of life is a crucial and very important part of our lives as human beings. But it can be a precious time only if we are free from pain and free for lack of comfort. So controlling symptoms, it's a very important activity in palliative care, and we have to be good at it. So it's a good idea to revisit regularly how can we achieve a pain-free situation at the end of our lives. I have no conflict of interest of any kind with the pharmaceutical industry in this presentation. And what I'd like to do with you is to explain to you why sometimes morphines and opiates like morphine are not enough, and what can we do? Well, if I put my finger on a very hot spot in the kitchen, suddenly pain arises. Why? Because in this finger, there are many receptors sensitive to pain. Pain due to pressure, pain due to temperature, pain due to inflammation, pain due to cold. And this will send a special signal into my nerves by allowing sodium to get into cell where there is normally no sodium. Immediately, this produces a potential of action, depolarization, and a red star, which is a signal of pain. And this signal of pain will carry onto the nerves and arrive into my spine, where it connects to another neuron here, who goes to the brain. And then the brain knows that I have a problem with this pain at the end of my finger. This is the first neuron coming from the neuron to the medulla, and this is the number of red stars that shoots up because my finger is painful. As you see, this neuron does not connect directly with the second one who goes to the brain. How does the message communicate from the finger to the brain? Well, here, there's this neuron releases yellow dots that are sodium glutamate. And when the sodium glutamate gets released, and then it gets into the second neuron with the sodium, and there's another sodium that is internalized in this second neuron. When this occurs, this glutamate within the vesicles are expelled, arrives to a receptor in the second neuron, sodium glutamate gets in, and here again there is a excitation which will move forward until the brain. This sodium entry is related with the glutamate release here. Note that this release of glutamate can be regulated by opiates. So if I put morphine here, instead of having one yellow bead for a red star, I only have half of it or a quarter of it, and zero. And when there is zero glutamate flowing out, there is zero pain experience in the brain. Whoop, I'm sorry. What does the opioid do? The opioid change the nature of the adenylyl cyclase activity and reduce the reign of the yellow spots to the other neuron. When we give some morphine to somebody who has some pain, suppose that I give only 50% of what is required, the pain will be reduced by about 50%, and we will give breakthrough dosage to improve the situation. And after a couple of days, I know he needs too much breakthrough doses, so increase the main dose, have less breakthrough doses, and when 100% of the optimal dose is reached, there is no pain. There is no pain, but there is no sign of opioid excess either. The first sign of opioid excess is that your attention becomes slow and your brain becomes slow. Can you tell me the years and the name of the months in the year? Yes, doctor. January, February, December. Okay. Can you do that reverse-wise? And suddenly, it's impossible to go from September to August because there is no R in August, and the brain is not able to do this exercise anymore. This is a very subtle, but the first sign of intoxication of opiates. Note that this does not occur if there is no pain, but just enough morphine. It occurs when you start to give too much. But the pain can also be due to something else. The pain, which is called neuropathic pain, will be produced when you have an intense and prolonged pain. This will change something we're going to see. Or if the nerves fibers are involved in the direct damage. Here, there's a lot of excitation. This lot of excitation due to sodium glutamate entry will slowly change the physiology of this cell. There's another receptor here called NMDA, and this receptor allows sodium and calcium to enter. But it does not enter with glutamate. It enters directly. You cannot regulate this entry with morphine. You can regulate this entry with morphine. So if sodium and calcium enters, to be able to enter, you have to expel a magnesium ion that sits there. And if you expel that because there's a lot of excitation, suddenly there's another entry of sodium in this cell. This is the receptor. This is the plug of magnesium. When magnesium is there, sodium cannot get in. If you remove magnesium, then sodium can get in. And what happens if you remove magnesium? Well, there's a free entry of sodium. And therefore, there's a full of starch arising in this cell, which become extremely excited. And the small excitation will provide pain. But it's not a pain that you can really regulate with morphine. It's a repeated pain stimulation due to the NMDA nucleus, which is stimulated. Overexcitability. And now even if you touch the skin, the brain interprets that it is pain. It's called allodynia. Well, the pain does not go because you are doing something painful, but it's interpreted by it. as painful. And your neurons in the medulla starts to grow, to become very large, going up and down. And now the small spot of painful skin becomes a large spot of painful skin. Allodynia increases. And the patient experiments pain crisis, short episodes, allodynia increases, and he needs more and more pills to kill this pain. But the morphine that you give now cannot kill this pain. Now, what will happen? Well, you're going to see sign of toxicity without a complete pain-free situation. And this tells you that there is something which is not opioid sensitive, that provides pain, that you can't kill with more morphine or the like. And if you continue to give morphine, you will still have pain, but now have an intoxication with the opioids. What can you do? Well, what we can do is to block again the NMDA channel. How can we do that? Well, methadone is one way. This is the NMDA. If you super stimulate the cell, the magnesium goes out, calcium and sodium goes in the cell and increase the sensitivity, the amount of pain. Here, there's a spot where methadone or ketamine can block the passage. If you introduce methadone or ketamine, you will restore the impermeability of this. How do you do that? Methadone is an interesting molecule. In 1 milligram of methadone, 50% is on the L configuration and 50% on D configuration. Methadone on L communication is 10 times more potent than morphine. And since in 1 milligram there is 50% of L and D, 1 milligram is 5 times more potent than morphine. But the D form is a specific inhibitor of NMDA. So when you introduce methadone, you don't want to introduce more morphine. You want to introduce NMDA blockage. And if you do that, you will have an effect on the pain. And therefore, methadone is a powerful opioid, but also a powerful antagonist of NMDA. Methadone is a kind of dangerous molecule because it's very erratic in its metabolism from one people to another. In the old time, we were ceasing completely morphine and giving methadone instead of morphine. And by doing that, we need large quantities of methadone. I want to discuss another strategy where you're going to give extremely small amount of methadone, much less risks of a problem, and a proper use as a co-analgesia. It's absorbed rapidly, 100%. You can provide it under the tongue, so even if you're comatose and dying, you can still have your methadone, and it's stocked in the tissues very rapidly, and only 1% of the methadone stays in the plasma, in the circulation. Metabolism of methadone is through the liver and through the fecal excretion. You can give methadone even if there is no renal function. It's very safe in renal insufficiency. And we use it as tablets of 1 milligram. And I'm going to show you that we'll seldom need more than 3 milligrams 3 times a day in difficult pain. Or in solutions, 10 milligrams ml, a tenth of a ml contain 1 milligram, and a tenth of a ml is a very small amount. You can put that in the mouth. Even if you don't swallow, you're going to absorb this, and this is going to be efficient. And we use that when you have an opioid-resistant pain, what is called a neuropathic pain. And this, it takes often very small amount of methadone to obtain a good effect. Why? Because the NMDA is very sensitive to the part of methadone which is directed to this action. You don't have to change the opioid that you are giving. You just check the cognitive function to make sure where you start. If the patient already can't count the mouse in backward or cannot tell you what is 93 minus 7, if it's the accountant, they can't tell you that, there is a problem. You want to see how he is before introducing methadone, and then you have to reduce the methadone after 5 days because the stocking in the tissue ceases, and now if you don't reduce the dose, you will have too much. We will start with small dosage with the regular opioids, opiate on the board, increase slowly, and if there is a sign that there is too much, patient becomes a bit sleepy or not as sharp, you just skip a dose. This man is 68 years old. He's a social worker in our hospital. He consumed heroin for years. He's a drug abuser. Drug abusers need much more drug to control pain than non-drug abusers because they have dulled their mechanisms by the brain abuse. He's a cancer of the lung, metastasis at several places, including in the brain, and a very severe pain in the shoulder and the neck, at the same side that the cancer is. He cannot elevate his arm. It's too painful. He cannot cough. It's too painful. And we can see that he has a compression of the medulla in the cervical medulla. We see that at the IRM. He had radiotherapy for that, can't have any more radiotherapy, and in the hospital, because it's too painful, he can't live anymore like this. He's already taking hydromorphone long action and short action for a total of 20 milligrams of hydromorphone, which is roughly 100 milligrams of morphine equivalent. He has also other co-analgesia, pregabalin called acetaminophen, and has a very partial response to that, and we have to do something for him. What are we going to do? Change the opiate? It's a possibility. Introduce another pill? He already has a lot of pills. It's a possibility. We have chosen to introduce an anti-NMDA treatment because he has some allodynia, very important in the shoulder. Because he consumed, I will start with 3 milligrams, and that's the highest amount I will start with, but in this case, he needs 3 milligrams of methadone 3 times a day. After 3 days, no arm pain, normal arm mobilization, no sign of toxicity, no breakthrough needed, pain is 1/10. It's interesting success. He takes 9 milligrams of methadone. That's the equivalent of 45 equivalent of morphine. I have increased the total morphine equivalence a little bit, but I have the anti-NMDA effect. And it's not the slight amount of morphine that makes a difference. It's the NMDA. His pain after a few days stabilized between 1 and 3 on a 10 scale. I will reduce to 2 times 2 milligrams or 2 times I will reduce to 2 milligrams the methadone after 5 days because the tissue stockage is over, and I discharge him to CHSLD. He will get there. At this time, you need a permit to give methadone to somebody, and no doctors there have the permit. So I have to go and become, for a couple of weeks, a doctor of this CHSLD, and I will provide to him the required methadone. He will die with no pain after 3 weeks. It's not really with no pain, but not the excruciating pain that he had before. He can now speak, he can now have contact with his family, and his end of life is much, much more humane than it was. Co-analgesia, 9 milligrams of methadone. If I have switched and removed the dilaudid, the hydromorphone, and to change it with methadone, I would need 20 milligrams of methadone. Well, the chances that you have problem with 20 milligram of methadone because there's an inhibition of metabolism due to another drug is high. But it's much less high with 9 milligram. Therefore, it's a much safer way to provide the methadone. This analgesia was effective, controlled the pain, limited the opioid consumption, and it was preventing also hyperalgesia. Case number 2, pancreas cancer, 51-year-old. This guy come to see me in the clinical, external clinical, clinic externe. Outpatient facilities, thank you. I'm sorry, I haven't spoken English for a little while. And he come to see with an intense pain, nearly 10/10. He cannot walk. He cannot be flat on a bed. It's too painful. And therefore, he cannot go to have radiotherapy to improve his pain. He has some fentanyl on a patch on his arm, and he takes 4 milligrams of hydromorphone every 4 hours, 6 times a day. And despite that, he has nearly 9 or 10 on the pain scale. He takes too much hydromorphone, that's what he should not take, and what I will do is to introduce some methadone. Why? Because he wants to go home. I have demonstrated that he was responding to hydromorphone with a pill, with an injection under the skin, and therefore I have increased a little bit the fentanyl, but introduced 1 milligram 3 times a day, 1 milligram 3 times a day of methadone. Pain is reduced 3/10. He now can have radiotherapy because he can lie. He has 1 month of reasonable pain control, and he will die after stopping all medication for family internal problems that is not really related to the pain control. But at least during the last months of his life, he was much more comfortable. He was on 220 milligrams of equivalent morphine, and he would have needed at least 22 milligrams of methadone with a 10-to-1 conversion ratio. Normally, it's 5-to-1 when you have less than 100 of morphine, but 10-to-1 when you have more than 100 of morphine. And cholanalgesia was obtained with 3 milligrams of methadone. Methadone is a very cheap drug. It doesn't cost money. And there's no research on methadone anymore. There's no money to do with methadone. But it's a very useful molecule if you use it well. This person has a cancer of the left parotid gland in the neck, and he has a neuropathic pain, and he can't shave his left side because of the allodynia that is present on his face. Pain 10/10, and takes a lot of opioid, but with no effect. He takes the hydromorphone, he takes a breakthrough, and he has pain, plus signs of a toxicity. It's clear that he needs something else than just opioid. Because of this allodynic pain, tactile or too cold, we map this to make sure that there is a regression of this surface if there is an effect, clearly, and he has a living a tube in the nostril. He's fed by the tube. But the tube is close to the cancer area and can contribute to pain. And therefore, we're going to choose to give him methadone in a liquid form, 0.2 ml of a 10 milligram per ml solution, to have a local effect on top of the systemic effect. And what is going to happen? In 24 hours, no allodynia. Pain is reduced 2/10. He's able to eat again, and he takes no breakthrough. The very small amount of 1 milligram given directly has controlled the pain. And it is clear that he was taking a lot of opioid. Another case of trigeminal neuralgia, exactly the same picture, was this patient discontinued all other opioids and stayed only on 3 milligrams a day of methadone for a year with no difficulty. I skipped this one. We also will use methadone in Welsh grape juice for mucositis secondary to radiotherapy. Quite interesting. And we are very careful that patients should not take inhibitors, antibiotics that we give for fungi infection in the mouth because this blocks methadone metabolism. It's the same thing that having twice or thrice the dose of methadone if you are on fluconazole. If the patient becomes drowsy, you immediately stop one dose or 2 doses. Easy. You can do that over the phone. Please do not take your next dose of methadone. When you stop methadone, in many cases, the patient will be free of symptoms for a long time. So even if you don't have the benefit to follow him for a long time, if you take 2 or 3 weeks of methadone, well, the NMDA has been calmed down and will stay calmed down for a long time. Sometimes it is not true, and sometimes we have to add some ketamine to methadone. Why? Because there are several receptors in the NMDA receptor family, and then when methadone is not enough, we can also add ketamine to that. So it's possible to mix both. Small doses, less toxicity. Potentialization of the other opioid. Acceptability per patients, because we told him that the junkies take 80 milligrams a day of methadone, not 1 or not 2. So he's not a junkie. He has not the dosage that we will give to junkies. Reduce risk of hyperalgesia, and the positive effect may last for a long time. We start with small dosage. We increase slowly. We always estimate cognitive ability before and after. Each time we increase a drug like an opioid, we have to do that. And we reduce by 30% the dose after 5 days. If there is a problem, for a reason that we don't understand, we skip the dose. Of course, if the patient is hospitalized, we have to say to other doctors that this guy has some methadone because there's drugs interactions. And we will ask the patient to follow his state and the family to watch for constipation because it's an opioid like other opioids. And we will give sublingual doses if the patient becomes comatose. It's not because you're comatose that there is no pain. And you have a comatose patient pain-free. And we can decide, we can see if the patient is pain-free, even if he can't speak, because he is comatose. This is a very short overview. If you're interested, the Society of Doctors, Palliative Care Doctors that we created a few years ago, published a 46 pages review on the procedure to use methadone as a co-analgesia. Much more details there. You can find that freely on the Paliscience site of La Maison Victor Gadbois. La Maison Victor. And you have it in the PowerPoint. Thank you. And you will have it in the PowerPoint. This, of course, is much more elaborate than what I could do with you in 45 minutes this morning. And therefore, please, if you want to use that, read this, the precautions that around this use of methadone. I'm convinced that we cannot be a good palliative care doctor if you cannot control the critical situation at the end of life. It's a moral and a medical obligation, and we cannot go without methadone, especially for people who have cancer, either of the mouth area or the other side. You know what? Because at some time in life we were like worms, going from right to left, the mouth was the mouth, and going from left to right, the anal orifice was the navel. Therefore, there's a lot of nerves around those two orifices, and they are subjected to give very painful neuropathic pain. I always need methadone for cancer of the mouth of the area or on the other side. It's too difficult without it. And therefore, we need to understand what methadone do. How can we start methadone? How can we do it simply without changing the rest of the medication? How to follow the first days, because the first days are the more important to make sure that you're giving the proper dose, and how to inform the medical community around you what you have done for this patient. I thank you very much.